Whenever you're ready.
All right.
But I think we're supposed to close the doors. And
What's that? Doors? I got it.
greetings and good morning. Please give me feedback as to whether or not you can hear me appropriately.
Taking a few seconds to respond.
Roger.
Meters are looking good, so it should be good.
I'm Richard Sweeney. Have a doctorate of medicine, and I'm a fellow of the American Academy of Emergency Medicine. I'm part of the core teaching faculty in the emergency medicine residency here at Freeman West in Joplin, Missouri. My first day of medical school, I recall having seen a slide similar to this with the admonition of first, do no harm. This is attributed to Hippocrates. At the time, I thought it was a little odd because the quote is in Latin and Hippocrates wrote in Greek, which is just one more sign that sometimes what we see or teach in medicine has changed over time. The quote in Latin actually comes from medieval teaching of Hippocrates after it was translated into Latin. So, what is excited delirium? And I put the term excited delirium in quotes because, as you'll see, it's no longer supposed to be used. Pretest. What is excited delirium? Is it a potentially fatal state of extreme agitation and delirium, usually associated with substance abuse? Is it a term that came to prominence in the 1980s, forensic literature, used to explain deaths in police custody during or after restraint? There's a strong association with cocaine abuse at the time. Is it a term that has been accepted by the American College of Physicians? Is it a term that's been rejected by the American College of Physicians and replaced with the term hyperactive delirium syndrome with severe agitation? Is it a high-stakes situation that can easily result in a patient intentionally, seriously injuring or killing you or members of your team? Is it a high-stakes situation that can easily result in you or members of your team accidentally, seriously injuring or killing your patient? Is it a term now alleged to be controversial, pseudoscientific, and racially based? A phrase you should avoid using in your documentation? Or is it a medical legal nightmare? All of the above. Excited delirium is now considered an obsolete term. It came to prominence in the 1980s in forensic literature when it was being used to explain deaths in police custody during or after restraint, usually associated with cocaine abuse. It is now called hyperactive delirium syndrome with severe agitation. They've changed the name, they've kind of changed it around the edges. It's the same entity. But if you see reference to it, that generally means that your reference material came out before 2023. There is a 132-page ACEP task force report. This will be a summary of the findings. Hyperactive delirium syndrome is characterized by, and they put this in very vague terms, combination of abnormal vital signs, agitation, altered mental status, and metabolic derangements. Well, that's really helpful. They use the term syndrome because if you use the term syndrome in medicine, it means we don't actually know what it is or what causes it. We are just going to describe it as a group of symptoms, and you treat the symptoms because we don't know what it really is and we don't know how to treat it. The symptoms being hyperactivity, altered mental status, and severe agitation. Why did the term excited delirium fall out of favor? It was being used as a cause of death on death certificates, but it's not necessarily a fatal illness. This led to allegations that it was a misappropriation of medical terminology used by law enforcement to legitimize, quote, police brutality, and to retroactively explain certain deaths that occurred in police custody. Now, the one thing that you really want in terms of people weighing in on the emergency medicine community is a diverse group of neurologists. When did the term excited delirium fall out of favor? In 2023. You'll see in the National Association of Medical Examiners said it should not be used in March. In April, the American College of Emergency Physicians changed the name, and then in October, California banned the use of the term as a cause of death on death certificates. Because it is a syndrome, it can be caused by a lot of different stuff. But substance abuse, and substance abuse are the top three causes. You can also see it in certain psychiatric illnesses not associated with substance abuse. And you'll see in the psychiatric literature, quote, excited or malignant catatonia. I would look that one up. Serotonin syndrome is something that can present very similarly, and that's something to be aware of, that not everybody who is behaving this way is necessarily on drugs, just the vast majority of them. You can also see it in thyroid storm and neuroleptic malignant syndrome, but again, it's often precipitated by substance abuse. It is incredibly important to remember that this is a potentially fatal state of extreme agitation and delirium. What does it look like? I'm trying to link to a video. Having some technical difficulties. That is exactly what excited delirium looks like. But excited delirium is not what killed him. What is positional asphyxia? This is a photograph from an Australian restraint, and these police officers are restraining this individual in the prone position, which is for their own safety and for the individual safety is the practice. It is still common practice worldwide. But you'll notice that the restraining officers, one is on the legs and the other two are on either side. Positional asphyxia, also known as postural asphyxia, occurs when someone's position prevents the person from breathing adequately. People may die from positional asphyxia when the mouth and nose are blocked or when the chest cannot fully expand. In the case of George Floyd, they were blaming the officer who had was compressing his neck. I strongly suspect that officers compressing his chest may in fact have been to blame. Why? Well, we'll get to that. Positional asphyxia is a term that came to prominence shortly after excited delirium in the forensic literature. Positional asphyxia was noted as the cause of multiple deaths in custody associated with the hog tie or hobble prone restraint position, that same position that I was showing you here. It's because the chest is not able to expand as well. Among other things, I'm a licensed master falconer. I use positional or postural asphyxia to humanely dispatch prey, mostly rabbits and squirrels. Why? Because normally red-tailed hawks and other raptors eat their prey while the prey is still conscious and screaming. I use postural or positional asphyxia to quickly dispatch the prey so the prey is unconscious. I do this by firmly compressing the chest wall. By increasing thoracic venous resistance, that essentially halts cerebral blood flow. Loss of consciousness occurs within seconds. For those of you who are familiar with mixed martial arts, the rear naked choke can similarly decrease cerebral blood flow so that the individual loses consciousness in seconds, unless this is immediately recognized and reversed. Hey, he's not responsive anymore. Cardiovascular collapse follows. And that's how many patients with hyperactive delirium with severe agitation end up dying. How deadly is it? I've had one coworker killed by a patient with hyperactive delirium with severe agitation. I have had many coworkers injured. I've seen numerous law enforcement officers injured each year. I saw one law enforcement officer repeatedly punch a patient in the face to the point that I had to get between the officer and the patient's face and excuse the officer and intubate the patient for his own safety. One patient was killed with positional asphyxia by security personnel outside a bar in Springfield. He was drunk. He was trying to leave. He crashed his car into another car. They dragged him out and sat on him till police got there. He was dead. Resuscitation attempts were unsuccessful. Had one patient who was almost killed by my coworkers who were coming to my rescue. He was large, he was altered, he attempted to punch me in the face. I grabbed his arm. My coworkers came to help. We got him onto the gurney, face down, with his chest on the gurney, but his legs still on the floor. Because I was familiar with positional asphyxia, I was the only one in the room who realized when he lost consciousness. We flipped him over, intubated him, and he went to the ICU. He was able to leave the hospital the next day with no neurologic sequelae, but only because I recognized his loss of consciousness and intervened immediately. Had another patient who was turned into an organ donor by pre-hospital esophageal intubation. He was absolutely crazy violent in his handcuffs. And the choice was made to intubate him to protect staff and police, with catastrophic results. You will hear the maxim, your first duty is to protect the patient. For normal patients, that is appropriate. Your first duty to be able to take care of your patients is to protect yourself, because you have to play by the rules and the patient does not. There are no timeouts, there are no referees. You can look forward to lawyers dealing with the situation, but your patient can kill you. Your first priority is to protect yourself and the people around you. Watch for biters and stay above the knees. Do not grab somebody by the feet to attempt to restrain the lower extremities. Protect yourself, protect the others on your team, and protect the patient. Be aware, severe agitation can be contagious, particularly when a patient is requiring significant force for physical restraint. Other members of your team may start to lose it. They may use excessive force. I've seen a police officer punch my patient repeatedly in the face. I've seen other members of the team striking rather than simply restraining. The most experienced member of the team should be managing the head, monitoring the patient's airway. Watch out for biters. I have had to knock aside coworkers' hands and arms because they were crossing across the head, and I have been bitten by patients. I have protected other team members from being bitten by patients. But you've got to be aware of that mouth, that airway, and you've got to watch out for your team to make sure that they don't get injured. Monitoring the patient and the team is a big task. Continuously work on talking the patient down and the team. As you're physically restraining, understand that you may have to remove any team member, including law enforcement, who uses force inappropriately during their restraint, and that you may have to sedate and or intubate to protect the team from the patient or protect the patient from the team. I've had to do both. Physical restraint is frequently, if not almost universally, required. Chemical restraint, the recommendations from the American College of Emergency Physicians includes benzodiazepines, antipsychotics, and ketamine. Although at last check, you didn't have the option of antipsychotics on your most of your ambulances. Be aware that benzodiazepines and ketamine can result in respiratory depression, and that physical restraint, especially if the patient is restrained prone or if the patient has handcuffs on behind the chest, this may exacerbate respiratory depression. And yes, the recommendations are for intramuscular injection. If you can get it administered IV, the doses are different, but yes, this is for a dart for patients who are so out of control, you just have to tranquilize them as you would an animal. Doses and time to onset are listed. And certainly a consideration, if that is not sufficient, once you can establish IV access, is whether or not to proceed with chemical paralysis and intubation. Be aware, and this is something I talk with my residents about all the time. Rule number 6, all answers are wrong. Some are just more wrong than others. No matter what you do, someone will criticize it. If you didn't intubate them, you should have intubated it. If you did intubate them, you shouldn't have intubated them. If you sedated them, you shouldn't have sedated them. If you didn't sedate them, you should have sedated them. All answers are wrong. Somebody is going to complain no matter what you do. So you have to make the decision based on keeping yourself safe, keeping the members of your team safe, and keeping the patient safe. Monty knew the patient. The patient taunted him about his family. And rather than act out, he started to turn away. The patient was on the gurney on his back with his hands cuffed. He kicked Monty in the back of the neck. Monty had a vertebral dissection. And was brain dead. Stay above the knees. When restraining a patient, restrain legs with both hands above the knees. Whatever you do, stay above the knees. First, do no harm. Second, go home alive. Questions?
Stream's probably 20,
Yeah.
30 seconds behind us. Give it a few minutes. If anybody in the room has questions, feel free to shout them out now when we give the online audience time to kind of catch up to our current time.
I don't know if any of you have gotten pushback for sedating patients with excited delirium prior to ER arrival. You will not receive that pushback from me. I realize that you are trapped in a very small cage with violent, completely irrational individuals who have no compunction about harming or killing you.
You prefer Versed over ketamine or ketamine over Versed?
Whatever you can get that will work, I have no preference. I have seen ketamine work better for the extremely violent, but whatever your personal experience is, and it's going to tend to depend to some extent on other issues. You may see, if somebody's really high on meth, you may see a better result. Well, I may see a better result by the time they get to me with Versed. But the issue for you, and we can go back to that onset, if you got ketamine and you got a 2 to 15 minute as opposed to a 10 to 20 minute choice, What am I going to be using? If I don't think I'm going to be intubating, I'll use Versed. If I'm seriously contemplating intubation, I'll use ketamine because you've got a better chance of getting them under control a little faster, and you're ready for the next step. Does that answer your question?
Ketamine is usually a larger amount.
Oh yeah.
So sometimes
I do not mind. The biggest issue is keeping you safe, and whatever you need to do to keep you safe. Succinylcholine can be administered intramuscularly. I don't recommend it, but if it's a matter of life or death, and you have a patient who is trying to kill you, you have to do whatever is reasonable and appropriate. And if you are traveling down the highway, you can't get out. And they will kill you. Other questions?
There are no questions.
Oh, okay.
A bunch of greats and wows and thank yous, but no questions.
Yeah.
From the online group.
I have been in a couple of situations where patients have, one went for the security guard's pistol. That is, I never want any of you, to be in that situation. I've had a paramedic tased. The officer got a little enthusiastic and pulled the taser and taser, and one probe went in the patient and one probe went in the paramedic. That was not exactly the word that was used by the paramedic, but she was a trooper. She was like, "Can you just kind of take that out?" But especially with some of the limitations that have been established for law enforcement personnel, they'll respond, but many areas they can no longer use non-lethal or sublethal munitions like beanbags to bring them down. They're being discouraged from, or having tasers and or stun guns taken away from them, and so they're having to, what they often encourage not to use physical force with nightsticks or things like that, and so then they're having to tackle and wrestle these individuals, and that's a recipe for disaster. I have wrestled my fair share of patients. I have been bitten or attempted biting because I'm at the airway end, and you've just got to protect yourself and your coworkers. I've lost count of the number of coworkers who've sustained orthopedic injuries in association with restraining physically violent patients. And that's when we have a whole crew. Often you will not have that option because you're back there with maybe one person to assist, and it's not a place I would want to be. Other questions?
Some of the questions from the online audience, just more thank yous and great information stuff. Anybody else in the room have any questions? Here and then, I guess we'll end the broadcast at least.
Okay.
All right, everybody will sign out for now. We'll